This video will discuss the assessment, diagnosis and treatment of femoroacetabular impingement. Femoroacetabular impingement is an impingement or abutment of the chondrolabral structures between the femur and acetabulum. We know that high activity athletes are at increased risk, and therefore it is an important diagnosis for the sports physiotherapist to be aware of. There are three types of femoroacetabular impingement: cam, pincer, or mixed. Cam impingement occurs when the patient has an aspherical femoral head and there is an abnormal head-neck junction with an increased radius at the waist. At extremes of range of motion, this will result in femoral abutment, causing shear stress on the articular cartilage and a subsequent labral tear or detachment. Pincer impingement occurs when the patient has excessive acetabular coverage or overcoverage. This overcoverage will cause femoral abutment against the chondrolabral tissues at extremes of range of motion. A mixed presentation is seen in the majority of cases and is a combination of the two. The diagnosis of femoroacetabular impingement is made both clinically and radiologically. Cloissy et al. 2009 studied the clinical presentations of patients with symptomatic femoroacetabular impingement. They found the athlete often presents with insidious onset of groin pain in 65% of cases and anterior hip pain in 83% of cases. The pain is often intermittent and is exacerbated in 65% of cases by both physical activity and sitting. A common misdiagnosis or competing hypothesis is a soft tissue injury of the groin or anterior hip musculature, and this is an important differential diagnosis to be aware of. Objectively, Philippon et al. 2006 found a significantly reduced range of motion in the symptomatic side of patients with femoroacetabular impingement. They found differences in flexion of 9 degrees, in internal rotation of 4 degrees, and in AD deduction of 3 degrees. The hip impingement test was positive in 99% of cases and Faber's in 97% of cases. These results are similar to these ones shown here, where in 88% of cases the anterior impingement test produced anterior groin pain, 69% of patients has a positive Faber's, and 55% of patients had a positive resisted straight leg raise. Imaging can confirm the clinical diagnosis of femoroacetabular impingement. Osseous abnormalities are identifiable on both X-ray and CT scanning. An MRI can be utilised to identify articular cartilage and labral pathologies. Keeney et al. 2004 evaluated the use of MR arthrography and showed limited sensitivity of approximately 47% for articular cartilage pathology. Fortunately, they showed high specificity of 89%. This high specificity makes a positive result much more effective, resulting in a positive predictive value of 84% and an accuracy of 67% for cartilage damage. Therefore, labrum MR arthrography seems to produce superior results. Bird et al. 2004 found a false negative of 42% with MRI imaging. However, this was only 8% when using MR arthrograms for labral tears. The superiority of MR arthrography is also echoed by this study, which showed a 91% accuracy for MR arthrography as opposed to 36% for MR alone. Now to treatment. Conservative physiotherapy management, unfortunately, is often unsuccessful in young, highly active athletes. However, it may be helpful in some patients. Initially, the aims are anti-inflammatory in nature. This includes rest from aggravating activities and electrophysical modalities. Other techniques you may find useful in the early phases of treatment are pelvic and gluteal strengthening, core stability strengthening, gentle stretching, and sometimes mulligan or lateral hip distraction techniques are useful. As previously stated, the majority of athletes will require surgery. Ning et al. 2010 performed a systematic review on the efficacy of surgery for femoroacetabular impingement. They found that surgery was beneficial in the majority of presentations, approximately 70%. They also showed worse surgical outcomes were associated with increased levels of osteoarthritis, and these patients generally went on to have a total hip replacement. Beattie et al. 2008 compared the outcomes of two surgical techniques: open and arthroscopic treatment of labral tears and femoroacetabular impingement. They found insufficient evidence to support open surgical dislocation, which was the historic and supported gold standard, as a superior procedure to arthroscopic management. Now what many of your athletes will be interested in, return to play outcomes. Philippon et al. 2007 assessed the use of arthroscopic decompression in 45 professional athletes. The athletes, who were mostly male and hockey players, underwent surgery followed by an individualised and unfortunately poorly described rehabilitation period. The athletes were allowed to return to play at 12 to 16 weeks post-operatively. Fortunately, 93% of athletes returned to professional level sport. Interestingly, 78% of these athletes remained active in professional level sport at follow-up, which was an average of 1.6 years. So what are the clinical implications for sports physiotherapists? Femoroacetabular impingement should be considered as a cause of groin pain, particularly in an athletic population. Early and correct diagnosis is essential, and it also is important to remember to rule out competing hypotheses. Radiography should progress from initial X-ray to MR arthrography to fully assess pathology. The athlete should be educated on the usual clinical pathway of femoroacetabular impingement, which includes a low response to conservative management. The athlete should undertake a short-term conservative trial, and surgical interventions should be considered early given the failure of conservative treatments, as the development of osteoarthritis will decrease the probability of a successful surgical outcome. Finally, arthroscopic decompression will allow the majority of professional athletes to return to play. If you would like more information, you can also catch us on Facebook at facebook.com/thesportspt, on Twitter by following @thesportspt, and for more information and a full reference list, please visit thesportsphysiotherapist.com.